Okay. There we go. And one final podcast to make you aware of is our IVAC podcast with discussions about the COVID-19 epidemic and the vaccines. And as we know, another round of vaccines are available. So these are certainly timely topics. Because this is a CME accredited webinar, I need to remind you of the IAFP's CME accreditation. The AAFP has reviewed this health equity in LGBTQ and gender affirming care and has deemed it acceptable for 1.0 live AAFP prescribed credits. The physician should claim credit only with the extent of their participation in the activity. And I have put the credit claim in the chat. And now I'm going to turn it over to our co-chairs, Dr. Andrea Haynes and Dr. Ronald Rembert, to talk more about the Health Equity Member Interest Group and to introduce tonight's presenter. Thank you so much for being here. And now Dr. Haynes and Dr. Rembert.
Thanks, Jenny. And welcome everybody this evening. Are there health equity and diversity topics that move you and resonate with your professional interests? The Health Equity MIG or Member Interest Group is open to all IAFP members. Our priorities are to assist the IAFP in planning, attending, promoting health equity education events, such as the State of Illinois required CME, as well as share best practices and challenges of implementing health equity in your practice, your organization, and your community, and to disseminate and update the Health Equity Resource Center and assist other family physicians to incorporate health equity in their practices, organizations, and community. You can join us at iafp.com. It's under the membership tab. So our commitment, the IAFP will support diversity, equity, and inclusion for in all of its forms, recognizing that these require an enduring commitment that must find full expression in our organizational culture, values, activities, and behaviors. Now I'd like to introduce a co-chair of our Health Equity Member Interest Group, Dr. Andrea Haynes, who will be introducing our presenter for the evening, Dr. Christopher Veal. Thank you.
Good evening, everyone. I would like to introduce Dr. Christopher Veal. He is a certified trauma-informed care physician and family medicine resident physician at Carle Foundation Hospital at the University of Illinois, Urbana-Champaign. He has established himself as a leading advocate for change in the areas of suicide prevention, mental health, and LGBTQ health. He is an award-winning writer who has been published in several peer-reviewed journals, including the Annals of Internal Medicine and Academic Medicine, and has been a contributing author to MedPage Today. His most recent publication, We Burn Out, We Break, We Die, was awarded the John A. Benson Professionalism Article Prize for Best Article of 2021 by the American Board of Internal Medicine. He has worked closely with the American Academy of Pediatrics, the National Institute of Mental Health, and the American Foundation for Suicide Prevention in developing a revised blueprint for youth suicide prevention in the United States. He also serves as faculty for AAP and AAFP ECHO course for youth suicide prevention. He was recently featured on NPR and was the keynote speaker for the NIH LGBTQ Youth Suicide Prevention Summit, speaking on the importance and need for greater access to gender-affirming care. Upon the completion of his residency training in 2024, Dr. Veal will be joining Howard Brown Health in Chicago, Illinois, as a primary care physician, focusing on trauma-informed care, adverse childhood experiences, gender-affirming care, and LGBTQ health. So these are the learning objectives that that Dr. Veal will go through tonight. So first, identify the negative effects of implicit bias and discrimination can have on the mental and physical health of those in the LGBTQ community, including gaps in services and treatment. Second, promote changes in policies and practices to create a healthcare environment in which persons in the LGBTQ community feel safe, validated, and welcome. And then the third objective, identify specific health-related risks and needs experienced by the LGBTQ community, and then discuss the basics of gender-affirming care. I now present to you Dr. Christopher Veal.
Thank you so much. So appreciate it. Okay, so I'm gonna share my screen, and hopefully this winds up working. I'm gonna need to try to share my PowerPoint. Okay, let's see here. Okay, so Jenny, I believe that if I put this in this mode, is there a way I can also put it in presenter mode on my end and have you guys see the slides on your end? Do you know
Would need
how
two
that's possible?
screens to do that.
I would need two screens to do that.
Yeah.
Perfect. Perfect. That's just awesome. Okay. Give me 1 second because I did have some notes that I wanted to make sure were available. Hold on 1 second. I'm sorry
If
guys.
you'd
It's
like,
been
I could run the slides and you can use your notes.
Do you
on.
mind? Actually, that would actually be, that would be helpful.
That's what I'm here for.
Oh goodness, this is a treat. Okay, let me stop sharing. Thank you everyone for your patience. These things happen. We're in the era of Zoom, so yeah, I appreciate everyone for their patience here. Let's see here if I can get my notes.
Okay. There we go. And okay, away you go.
Okay, great. Let me just get this. I have my computer is frozen. Hold on 1 second. It's just perfect. Oh, goodness gracious. Okay. Give me 1 second, guy. I'm so sorry. This is just the perfect timing for this to happen. My computer just is not, it's not working right now. Oh my goodness. Hold on 1 second. Start reopening it. All right. My goodness. Okay. Bring it way up. Good. Take care of that. Okay. All right, sweet. I think we're good to go. Okay, so thank you everyone for your patience. I really appreciate that. Can everyone still hear me and see me? So make sure that the slides are up. Okay, good. All right. So yeah, we can advance aside. My name is Dr. Christopher Veal. As Dr. Haynes was saying, I am gonna be working at Howard Brown Health starting next year, and they're a really great place that does a lot of great work in terms of gender affirming care and LGBTQ health. So it really is an honor to be here to discuss this topic with you because it really is a central piece of my career. These are all objectives that we've already gone through. You can advance the slide. All right. I have no disclosures. I am still poor until I finish residency. I can move on to the next slide. And okay, perfect. So let's start things off by talking about language. There's three parts to this presentation. The first part is really in regards to just making sure we all are on the same page in terms of terminology and language as it refers to the LGBTQ community. So let's start by first defining sex and gender. So sex is based off of biological characteristics, including chromosomes, internal and external genitalia, and hormones. Historically determined by anatomy. Gender based on identity, social and cultural characteristics. So it's more of a social construct that's influenced by societal, institutional, and interpersonal relationships. Understanding the difference between the two, sex and gender, is important for understanding why certain health outcomes may occur and choosing appropriate interventions. So, for example, if a health outcome is related to sex, then the appropriate intervention might be more biologically focused than medication or surgery. But if a health outcome is related to gender, then the appropriate intervention may be more socio-behavioral focused, so addressing gender norms. Then or help-seeking behaviors such as encouraging men to seek more help often, right? Because of the stigma of that. So those are kind of the differences and why I want to make sure we understand that. Diving further into gender, we have gender identity, which is a person's inner sense and feeling of being a girl, a woman, or boy, a man, or another gender, or no gender altogether. And then gender expression, which is how a person shows their gender identity to others through their appearance and behavior. Understanding the difference between gender identity and gender expression is critical to not making assumptions about how a person identifies their gender based on how they choose to present themselves. Incorrect assumptions may lead to microaggressions, such as using incorrect pronouns, gender language, and making assumptions about a person's life experience. These microaggressions ultimately lead to a mistrust between the patient and the provider and a reluctance to seek healthcare in the future. So that's why I want to make sure we are all on the same page in regards to that. Go to the next slide there. Okay. So to many folks here, transgender terms and concepts may be less familiar. It's important to be familiar and comfortable with utilizing this terminology, both to have a better understanding and communicate with your sexual and gender diverse patients and help them be more comfortable, welcomed, and affirmed in their own identity. So a transgender person is someone who has a gender identity that is different from society's expectations based on their sex assigned at birth. Synonyms for transgender include gender minority or gender diverse. On the other hand, someone that is cisgender is someone who has a gender identity that is the same as their sex assigned at birth. So I personally identify as a cisgender male. I was assigned male at birth, and I identify internally and externally with being a man. Meanwhile, some people who are transgender may identify with their affirmed gender, such as simply saying I am a man, I am a boy, or I am a woman, I am a girl, rather than saying they are a trans woman or a trans male. That is purely their choice. Those that identify as non-binary can represent an identity that is a combination of woman and man or another gender altogether. Some people who are not binary identify as transgender, while others do not. Next slide. So gender dysphoria refers to the inner stress that a gender diverse person experiences when their physical body does not match their gender identity. When we talk about the concept of gender affirmation, we're talking about the process a transgender and or non-binary person takes to live as their affirmed gender. The process of gender affirmation is unique to the individual, and it can involve a variety of different steps, including social steps, so like learning and using a different name or pronoun, or changing their gender expression, legal steps, so like legally changing their name on a driver's license or birth certificate. Oh, sorry, hold on one second. Just had another problem with my computer, sorry guys. There we go, we're back. And then medical steps such as taking hormones or having surgery to bring their body more in line with their gender identity. Next slide. I do want to take a moment to go over some terms that are considered outdated and or unaffirming for the transgender community. Some of these terms may still be used by members of the transgender community, but they should not be used by cisgender people unless a transgender person expresses their preference for that term. So, looking at this list here, avoiding terms such as hermaphrodite, transsexual, gender dysphoria, gender variant, sex reassignment surgery, sex change, with those specific terms, when it comes to, gender affirming surgical transition, the more preferred terms to use are gender affirming surgery or gender affirming medical treatment. So those are I just want to make sure that people are aware of that, especially when it comes to, patient encounters with people who are transgender. All right. In regards to sexual orientation, it's best to think about this through three primary dimensions of through three primary dimensions. So there's attraction, behavior, and identity. So, the sexual or romantic attraction that someone has for another, the behavioral or the engagement in sexual behavior with that person, and the identity or label that person feels most closely aligned with. These three dimensions may be consistent within an individual person. So a cisgender woman who is attracted to men, has sexual relations with cisgender men, and identifies as heterosexual or straight. On the other hand, these dimensions may be inconsistent, right? So a cisgender woman who is attracted to and has sex with people of more than one gender and identifies as heterosexual or straight. Understanding the multiple dimensions of sexual orientation is important for us as clinicians to deliver appropriate and adequate care for all our patients. Okay. All right, go back one more, one slide. Yeah, sorry about that. All right. And finally, we have the myriad of acronyms that we use to attempt to be as inclusive and specific as possible when trying to define this beautiful and multifaceted community. They may be wondering which term is the most politically correct, or inclusive term to use. Is it gay, LGBT, LGBTQ2 plus, LGBTQIA plus, SGM? What even is SGM? The truth of the matter is that over time, the language we use to help us identify and define this community has evolved and changed with time, right? Similar to how the identification of Black people in this country has evolved from Negro to colored to African American, Black, BIPOC. But for the sake of simplicity, I will be using the term that is most inclusive and easiest to rattle off in a sentence, which is SGM. This stands for sexual and gender minority. This term is more broadly references the LGBTQIA and other populations whose sexual orientation and or gender identity and reproductive development is considered outside cultural, societal, or physiological norms. Not everyone has a solid foundational knowledge regarding SGM terms and concepts, so we can dive into understanding the health inequities facing those in the SGM community. Let's get some water here. You can advance the next slide. Okay, so what are some of the health disparities faced by SGM people? Well, there are a variety, but in general, it has been well established that lesbian, gay, and bisexual people in the United States continue to have worse health and less access to health care than their heterosexual peers, right? So this includes higher rates of, poor or fair health status, severe psychological distress, increased instances of foregoing or delaying medical care due to costs. SGM, LGBTQ plus people are at greater risk of dying by suicide, of cardiovascular disease, some cancers, and really a cascading list of other health problems. The community in which SGM people live has a great impact on their health and overall longevity. One study in 2014 showed that SGM people living in communities with the highest level of prejudice against sexual minorities die on average 12 years sooner than peers in communities with the lowest anti-LGBTQ prejudice, even when other individual level and community level factors such as pre-existing illnesses are accounted for. So this is a pretty significant, statement here saying that your environment matters just as much as you are as well. And it should be noted that disparities exist within the SGM community themselves as well. So studies have shown that transgender people having worse health outcomes than cisgender people and people with plurisexual orientation, so those who have sexual orientation toward more than one gender, and non-binary gender identities fare worse than people with monosexual orientations. So those who have a sexual orientation only toward one gender, and binary transgender identities. Okay, next slide. All right, I love history, so I always think it's important to kind of bring the historical context into these discussions of health equity. Most SGM people encounter stigma from an early age. This experience shapes how they perceive and interact with all aspects of society. This includes health-related institutions. Likewise, heterosexual people, including many healthcare professionals, have been socialized in a society that stigmatizes sexual and gender minorities. And this context inevitably affects their knowledge and perceptions of SGM people. Throughout much of the 20th century, consensual sexual behavior was illegal, and homosexuality was considered a form of mental illness. this dual stigma historically attached to homosexual behavior, and people have shaped the experiences of many people living today and has influenced many contemporary institutions that affect health. With this in mind, it is easy to understand how most health disparities for SGM people are rooted in and reflect the historical stigmatization of SGM people. Through the World War II era, sodomy laws were created and criminalized same-sex behavior, even when it occurred in the private setting of someone's own home between two consenting adults. In the 1950s, we have McCarthyism, which resulted in the publication of a U.S. Senate committee report concluding that homosexuals were not qualified for federal employment and that they represented a security risk because they could be blackmailed about their sexuality. So in response to that, President Eisenhower issued an executive order dismissing all homosexuals from federal employment, both civilian and military. By 1952, the newly created DSM listed homosexuality as a sociopathic personality disturbance, along with the substance abuse and sexual disorders. This classification of homosexuality was used as a basis of laws and regulations that denied homosexuals employment or prohibited them from being licensed in many occupations, including medicine. At the same time, emerging gay and lesbian communities and enclaves in large urban centers offered their members the opportunity to meet others who shared their identity and sexual orientation. These communities provide a basis for the development of organizational and individual challenges to stigmatize status of homosexuality. Jenny, if you can click once, thank you so much. So over time, the stigma associated with SGM identities within the medical community has decreased as SGM visibility and their activism has increased. This is reflected in how DSM diagnoses of SGM people has evolved from a more pathologic definition to a more gender affirming one. All right, moving on. So one cannot discuss SGM health inequities without discussing the role of minority stress. So minority stress is defined by the experiences of prejudice and discrimination based on stigmatized identities, so distal stressors, such as well as the internalization of that stigma and prejudice, more proximal stressors, which adversely affect both mental and physical health, in part via a psychological stress response. So when we talk about that internalization, we're talking about internal minority stressors like the experiences of rejection and discrimination, concealment of minority identity, and internalizations of negative dominant cultural beliefs, negative dominant cultural attitudes, beliefs, stereotypes, and values. This leads to higher rates of internalizing psychopathology, such as depression, anxiety, self-harm, PTSD symptomology, which ultimately leads to externalizing behaviors, which lead to adverse physical health problems, such as substance abuse and suicide. This theory can be applied to both SGM and other stigmatized identities. So this is bringing in the concept of intersectionality. Next slide, please. Let's see here. I got there we go. Computer is not, I can write this morning or this afternoon, sorry guys. All right, intersectionality is the concept of how people's experiences occur at the intersections of different identities and social positions that are based on axes of power and privilege. So, talking about gender identity, sexual orientation, age, race, ethnicity, socioeconomic status, immigration status, disability status, et cetera, et cetera. One example of how intersectionality played a role in exacerbating health inequity can be found in a 2020 study that looked at health inequity among gender minority Black individuals compared to cisgender Blacks and gender minority whites. In this study, they found that in some cases, inequities experienced by gender minority Blacks were more similar to cisgender Blacks, like rates of diabetes, but in other cases, they were more similar to gender minority whites. So this was true with HIV risk factors and depressive disorders. For some aspects of health, such as cardiovascular disease and self-reported health, gender minority Blacks fared far worse than both cisgender Blacks and gender minority whites. Next slide. In the context of healthcare delivery, A recent poll done by the 19th News showed that 24% of LGBTQ Americans said that they had been blamed for their health problems while visiting a healthcare provider, compared to just 9% of non-LGBTQ plus people. For LGBTQ plus and gender nonconforming people, or those who said that their gender was not male or female, in addition to being LGBTQ plus, that number jumped to 40%. 16% of LGBTQ plus people and 26% of gender nonconforming LGBTQ plus Americans recounted being denied or refused medical services at a doctor's appointment versus 7% of non-LGBTQ plus people. LGBTQ plus people of color are even more vulnerable to the mounting effects of discrimination. 53% of LGBTQ plus people of color face discrimination in healthcare compared to 44% of white LGBTQ plus people. Overall, the most frequently reported reason for discrimination was the patient's perceived gender identity and or expression of masculine or feminine appearance, sexual orientation, and age. The key point I want you all to gather here from this data and information on the slides preceding it is that SGM health inequities can be explained by minority stress related to the stigma of being SGM, not necessarily about being SGM itself. The next slide. All right. Now that we have an understanding of what health inequities members of the SGM community face, let's jump into how we can be part of the solution by providing care that is trauma-informed, culturally competent, and gender-affirming. Creating welcoming, inclusive, and affirming healthcare environments is critical for increasing access to care for SGM patients. I found that the greatest resource for this is the 10 strategies for creating inclusive healthcare environments for LGBTQIA people, published by the legendary National LGBTQIA plus Health Education Center. This is a program of the Fenway Institute in Boston, which I'll tell you guys more about later. Let's go to the next slide. So tip one, actively engage leadership. So active involvement from members of the governing board and senior management is essential for building a health center-wide commitment to change. Ideally, at least one person from senior management takes on the role of a champion, quote unquote, for SGM inclusion efforts. This individual would set the tone for the entire staff by announcing new initiatives, explaining the goals and rationale for creating more welcoming environments, and scheduling all staff introductory trainings on SGM health. Administering an organization-wide survey to assess current practice and service gaps may also help to kickstart efforts. An SGM inclusion task force comprised of staff representing different roles and departments can be useful as well in regularly planning, implementing, and monitoring strategies and adjustments to build a more welcoming environment. Next slide. Tip two, creating organizational policies that protect SGM people. So adding the terms sexual orientation, gender identity, and gender expression to patient and employment non-discrimination policies and posting these policies in high-profile areas sends a clear signal to your patients of your organization's commitments and values. In an attempt to prevent harassment of transgender and gender diverse people in gender-specific restrooms, health centers can develop, post, and enforce policies that allow all people to use restrooms that best align with their gender identity. And lastly, folks in the SGM community often have a chosen family of friends who serve in the roles of caregivers and supports. Policies that involve caretakers and support persons, as well as policies on visitation, should use more broad definitions so that partners, children, and friends who have no legal status as family can be included when patients wish them to be. As with the non-discrimination policies, visibly posting these policies is another signal to SGM people that your organization affirms, welcomes, and values their presence. Next slide. Sorry guys, my voice is getting very, very hoarse as I talk today. It's been a long night. Okay, tip three, creating a physical and virtual environment that is welcoming to SGM people. So ask yourself, do the images on your health education materials, website, social media accounts, patient engagement tools, or marketing products include SGM symbols, diverse gender expressions, same gender couples, and SGM families? Do you develop health education materials specific to SGM people? Do you offer brochures and other resource materials from local SGM organizations? Do your waiting areas have local or national magazines or other reading materials that discuss SGM issues? Do you post articles or hang posters during Pride Month? All of these questions are opportunities to critically examine your healthcare setting and ensure you are providing a welcoming physical and virtual environment for the SGM community. Tip 4. Let's see here. There you go. Ensure your intake forms are inclusive of the multidimensional reality of SGM relationships. This includes reframing marital status questions as relationship status questions, having the option of spouse or partner instead of wife or husband, and parents or guardians rather than mother and father. In medical history forms, avoid specifying sections as applicable to only men or only women. Patients may have different body parts due to surgeries or hormones that may not align with traditional conceptions of male or female. So it's better to provide patients with the option to check not applicable. Next section. All right, tip 5, establish partnerships with the SGM community. So this can include hosting community events in collaboration with local organizations, recognizing SGM awareness days like National Coming Out Day, which is October 11th, Transgender Day of Remembrance, which is November 20th, and LGBTQ Health Week, which is varies what week it is in March, but it's typically in March. Also inviting diverse SGM people to join your health center's governing and community advisory boards is another great way of involving a community. Next slide. Tip 6. We're almost done, guys. We're halfway there. Encourage and ensure all staff are able to receive training on affirming communication and care. So this helps to ensure respectful communication with SGM patients, and ensure that they're happening at all levels of care. Clinical providers may also need additional training specific to their practice and the populations they serve. One of the better resources that I've seen and I've used in this presentation and also in my own profession is the National LGBTQIA Health Education Center, and others, which I'll discuss later at the end of this talk. Okay, tip 7, collect data on sexual orientation and gender identity and use this data to recognize areas of disparity for the SGM population and develop strategies to target these areas and improve health outcomes. So I know as a resident, we are required to do a QI project prior to graduation. This is a great opportunity for your residents to get involved and start tracking data, but also just in general to have, routine quality improvement measures. This is an area that many health organizations have not dived into that they very well should be diving into. Next slide. All right, tip 8. All patients should receive routine and inclusive sexual health histories. So I remember in med school when we learned about, doing a robust, history and physical exam. Even me as someone who's pretty progressive, who identifies as gay, had a very hard time with asking folks about their sexual health and their history and their practices. It's awkward, it's understandable. So, but it's important to kind of not only just normalize the conversation, but also be more comfortable with having it. So starting the conversation by stating that you ask these questions for all patients in order to provide appropriate care, right? Really standardizing it. This opening helps to normalize the conversation, asking inclusive questions that avoid assumptions, such as, are you in a relationship? And what are the gender or genders of your sexual partners? This invites patients to feel more comfortable disclosing sexual behavior and any related questions or concerns. The answers to these questions can then guide the clinician to ask about specific sexual activities relevant to, pregnancy prevention and HIV and sexually transmitted disease prevention, screening, and testing. Tip 9. We're almost done, guys. Ensure your clinical care and services are meeting the health care needs of the SGM community. And I cannot stress this enough, actually. Now, SGM people need the same healthcare and services as any one of us does, but there are certain SGM subpopulations that have specific and unique healthcare needs that should be recognized and attended to. So, for example, for our gay, bisexual, and other men who have sex with men and transgender women population, they have an increased risk of acquiring HIV and other STIs. So for this population, and this is something I practice myself in my own clinical practice, they require culturally responsive testing and prevention services. Health centers can be proactive by offering PrEP, pre and post exposure prophylactics for HIV. Also, something that is becoming more common, and I'm firmly behind, is the use of doxypep, doxycycline, available for people who are sexually active who are at risk of getting chlamydia, gonorrhea, or syphilis, basically being used as kind of like a morning after pill. These are really great like areas of prevention that really are tailored toward this specific component of the SGM population. And of course, anyone who also is interested in it. For lesbian, bisexual, and other women who have sex with women and transgender men, they are less likely than heterosexual cisgender women to be screened regularly for cervical cancer, despite having an equivalent risk. Quality assurance and improvement programs have been developed to ensure these populations receive culturally responsive care and trauma-informed cervical cancer screening according to current guidelines for all people who retain a cervix. So that's another population that needs additional focus. Next slide. With if you go to the next slide, please. Awesome, thank you. With gender affirming care, this is really a lecture in and of itself, but health institutions should be able to provide basic gender affirming care, such as hormone therapy, and be able to refer to specialty centers that offer gender affirming surgery. So, I will admit, in where I am at Carle Health, we are working on, ensuring that our patients have access to gender affirming care, but there's just not a lot of training in it. I mean, I went out of my way as a resident to learn more about gender affirming care and hormone therapy. Really, I think it's easier to do than diabetes management for a out of control diabetic or even hypertension management. But there's a lot of fear, for people in our profession. One, because of the stigma that I mentioned earlier, and two, because we just don't know how to have enough information. It's not part of the standardized curriculum. So one of the things I know the AAFP is trying to do is help to re-encourage and help encourage the ACCME on making gender affirming care training part of the curriculum. We still aren't there yet, but it is something that I think will be helpful. And I think that if folks are interested, they should be able to offer the service. And again, the education resources that we have are abundant and free. All right, so for family planning, organizations can offer counseling and referrals to agencies to support SGM people interested in becoming parents. And organizations can offer a range of behavioral health services to meet the needs of SGM patients with mental health and substance disorders, including individual counseling, support groups, medication-assisted treatment, violence prevention and response programs, and of course, trauma-informed care. Clinicians should also be trained to provide affirming treatment based on minority stress principles. And lastly, and I'll admit my bias in this tip, being recently hired by Howard Brown Health, SGM people should be recruited and retained in your health organizations. Health centers can aim to hire clinical providers who are either already proficient in SGM health, like myself, or demonstrate a strong interest in becoming proficient. Again, these trainings are not that, that's not medical school. It's a component of our profession. We're always learning. Implementation of protocols and programs that promote equity and community for SGM employees or allies can help with retention of these providers and employees, as well as ensuring employee health insurance plans cover gender affirming treatments and administrative guidelines support employees who are going through the process of gender affirmation. All right, so those are our 10 points. few final tips I want to make sure everyone kind of was aware of before I wrap up this webinar are just some do's and don'ts for your clinical practice that you can implement personally. So do explicitly ask your patients how they identify their gender. Do introduce yourself with your pronouns. Hi, I'm Dr. Veal. I use he, him pronouns. Default to using first and last names without an honorific. So honorifics being like, Mr. or Mrs. or mix, which is a gender neutral honorific. Until someone, kind of gives you an idea as to what honorific they want you to use. I think it's important to correct other people when pronouns and honorifics are being used incorrectly. So, the pronouns and honorifics are used as a sign of respect. And they're important for affirming a person's gender identity and helping a person feel seen by others. It's important to step up and correct others if they're using incorrect pronouns or honorifics to remove the burden from the patient to make this correction. Because honestly, these patients have to do it all the time. And, it shows that you care, that you're willing to go the extra mile to ensure that everyone is being as affirming as possible. Okay. And then ask questions about patients' attraction, behavior, and identity independently of one another. Don't make assumptions about patients and their partners based off their appearance and or behavior. Explicitly ask patients how they identify, acknowledging to the patient that you want to make sure you're not making any assumptions based on appearance. Don't belabor apologies. It's okay to make a mistake when a patient or colleagues with patient or colleagues' pronouns. Say something like, I'm sorry and thank you for correcting me. I have made mistakes many a time when it comes to saying the wrong pronouns or misidentifying someone. It's okay to make a mistake, but just it's important to remain humble, avoid getting defensive, and responding gracefully when you make a mistake. Using non-binary pronouns can take some practice, but most find it becomes pretty natural over time. And it's just best to apologize briefly and move on. I actually wind up, I think as of now in my point of life, I kind of just default to using they, them pronouns, when I refer to anyone. And so, if one wants to be overzealous like me in terms of doing that, I would recommend just kind of starting to use they, them in your normal vocabulary more often to get practice with that. And then lastly, don't skip questions on sexual orientation and make assumptions about the patient or their partners. Ask questions to clarify what their sexual orientation means to them. Okay. So in conclusion, just a few main points really. One, SGM health inequities can be explained by minority stress related to the stigma of being SGM. We all can make a difference in helping to change the narrative on SGM and LGBTQ health disparities, but it requires a concentrated effort at a variety of levels, of which I went through those 10 long steps on within the healthcare system. This includes education on SGM health inequity, really focusing on your words, they do matter, and also representation matters. Next slide. These are the lovely resources that I've used both for this presentation and that I would highly recommend you all utilize if you are interested in obtaining more information on SGM health. All these are free or low costs online and in-person training, with CME, especially at the National LGBTQIA Health and Education Center, which I think is actually the best. They offer a wide range of SGM healthcare topics, education, including behavioral health, sexual and reproductive health, transgender and gender diverse clinical care, HIV prevention and treatment, and care specific to children, adolescents, and older adults. So really big fan of that. Also, I have to plug my new employer, Howard Brown. They have a great health center for education and research and advocacy. And they have partnered with the AMA Ed Hub, which me as a resident, I utilize that for our credentialing and getting through our steps as residents. They have great education modules, so check those out for sure. And then of course the Center for Excellence for Transgender Health primary care protocols at UCSF, and then our own IAFP Health Equity page, which has a lot to offer on top of gender affirming care. information. So, or not, or you know, LGBTQ equity. These are our references. You can use those later. Next slide. Yeah, okay. I always try to end my presentations with some cool photos of my world. But thank you very much, everyone, for listening and enduring these technical issues I've been having in the meantime. So thank you, everyone. I'm open to any questions if you have them.
There are
Thank you,
no questions. Oh,
I'm sorry. Thank you, Dr. Veal, for that informative presentation. Can you tell us more about the Fenway Institute?
Yeah. Oh man, boy, can I. So yeah, I went to school at the University of Vermont for medical school and for undergrad. So in Vermont, we had a really close relationship with the Fenway Institute. The Fenway Institute is based out of Harvard, actually, Harvard Medical School. And so they really just took the lead when it comes to gender affirming care, LGBTQ health in general. Their resources are vast. I mean, what's even better is it's free. You know, I mean, I don't know of any other. I mean, I know that the AAFP, we have some great resources as well, but in terms of this specific topic and guidelines and best practices, they have such a great, like, robust network of resources. They're produced by Harvard Medical School. They have in these modules they have testimonials from actual patients and people who identify as SGM in a variety of capacities. And honestly, it's something that it's free CME, which is hard to get. So it's just I really do appreciate the resource, and I think that for someone like me who's still training, I think we all are training in from a we never stop training as physicians, but specifically for residents who are poor like myself, having a free resource like this is really helpful.
Awesome. Thank you.
Yeah. Don't all jump in at once. It's okay if you don't have any questions too. I'll just take that as a testament to my great speaking skills.
no, you really did. You really had a great presentation, and that served as, it was informative, but then also provided really concrete solutions that we can all take forward into our healthcare practices going forward. So really great presentation that you gave.
Thank you, Dr. Haynes. All the issues I was having earlier, so I appreciate the feedback. Thank you.
Any other questions? If there's no further questions, there's a link to the CME in a survey, SurveyMonkey, in the chat. You can click on that link to open that up so you can complete that for CME credit, and IAFP will be submitting that in October. Dr. Haynes?
Yeah, and so certainly as well, be sure to submit your credit, and then please join us for future events. We're still working to continue to bring others into these conversations as it relates to health equity. But we thank you all for your attendance tonight, and certainly continue forward in ensuring that we are providing health equity, especially for those sexual and gender minorities, but then other minority populations as well. So I hope you all have a good night, and thank you for joining us.
Thanks, everybody. Once again, thank you, Dr. Veal.
Thank you.